This conference will now be recorded.
Well, hello, everybody. Thank you for joining us today. We are here to introduce our newest gastroenterologist, Dr. Amanda Wenzel, and she'll be talking today to, actually, she'll be speaking to us today about diagnostic dilemmas in celiac disease. I would encourage any conversations or questions in our chat room that I'll be monitoring for you guys today. At the end of the presentation, we'll give you some information on how to contact Dr. Wenzel for referrals or for consultations. And just to let you know, she will be seeing patients at our brand new Glenview office, our new Skokie office in November, and in our Northbrook location. Speaking of Skokie, we will be opening our new Skokie location on November 23rd. And for those of you who don't know, it's on 3722 West Toohey Avenue, which is about 2.5 miles just east of the Edens Expressway. There we'll be having allergy, dermatology, endocrinology, gastroenterology, genetics, neuro, ped surgery, sleep medicine, urology, and at this location, we're going to have some great wraparound services such as cardiology with echo, orthopedics and sports medicine with medical imaging and ultrasound and CAT care. And we'll also have otolaryngology and audiology together. We will have blood draw and lab services, medical imaging and ultrasound, and physical therapy. So we're very excited to open up on November 23rd. So if you have any questions regarding Skokie, feel free to reach out to me, and I can hopefully answer all the questions. But at this point, I'd like to hand it over to Dr. Amanda Wenzel, and she is going to introduce herself and go ahead and talk about diagnostic dilemmas in celiac disease.
All right, I'm just getting my camera up here. Oh, perfect. Thank you, Chad. I appreciate it. Thanks for joining me today. Like Chad said, my name is Amanda Wenzel. I'm one of the new GI physicians at Lurie Children's. My clinical interests include inflammatory bowel disease. I'm one of the new physicians in the Inflammatory Bowel Disease Center. And then I also do general GI, and one of my passions within general GI is celiac disease. Not only because I think it's interesting and cool, but because my husband also has it. And so I do have a little bit of personal experience. So with that, I'm going to start. It was a narrow topic, but I do have a lot to get through. So let me bring this up. So I'm going to be talking today about diagnostic dilemmas in celiac disease. So here's an overview. We're going to go over a brief definition, some mentions about prevalence and how we think about prevalence in celiac disease. I'd like to focus a little bit on the non-GI manifestations to kind of help us gain some insight about what index of suspicion should be when testing for celiac disease, talk about our screening and diagnosis, pearls, talk about special at-risk populations that might be a diagnostic challenge, patients that have concurrent autoimmune diseases and first-degree relatives, and then dive a little bit into some of the diagnostic dilemmas that you guys might encounter when a patient sees us and then comes back to you, or things that we kind of deal with because although celiac disease is, there's not very many tests, there are some interesting clinical questions. So celiac disease, as we know, is an immune-mediated enteropathy caused by permanent sensitivity to gluten in those who are genetically susceptible. So only those with HLA-DQ2 and 8 are those that can develop celiac disease. It can occur in children with both GI and non-GI symptoms, and as I alluded to before, occurs in some asymptomatic individuals who have certain associated conditions that we'll discuss later in the talk. So one of my attendings introduced me to this concept of the celiac iceberg, and I think it's a really good way to think about the gamut of celiac disease. So you can see, if I have a pointer here, I don't know if you can see it or not, but I'm pointing to the bottom of the screen where, all of the individuals on this quote unquote iceberg have HLA DQ2 and 8. And so they're genetically susceptible. And then kind of depending on over time, those patients, may run the spectrum of having potential or latent celiac disease. They have the genetics, but they have neither symptoms nor is their intestinal lining damaged. Then you have those patients that are starting to develop intestinal lining, and over time you kind of reach that tip of the iceberg where finally your patients are symptomatic, and those are the easy patients. Those are the easier patients to diagnose. But there is still, this group of patients that are silent who do have intestinal damage but are asymptomatic, and those are kind of the prime patients that we want to have a high index of suspicion for and test for. So overall, those patients, we estimate that the prevalence is about 1 to 300 to 1 in 80 children. And to put that into perspective, in a pediatric practice of about 1,500 children, there are approximately 5 to 20 children with celiac disease. So it's not nothing. And I think the more patients that we can capture, the better those patients' outcomes are going to be as they, live with this chronic disease. So I won't go too much into the GI symptoms because I think, many of us are aware and attuned to what the GI symptoms of celiac disease are. We do see both patients with constipation and diarrhea, so I think you have to have a clinical index of suspicion on both ends of the spectrum. And then the one GI symptom I did want to point out, one that we often, think about, especially in liver clinic, are those patients with abnormal liver enzymes. And those can be, up to 5 times the upper limit of normal. So in patients that otherwise have an unexplained reason for their elevated liver enzymes, we'll often test for celiac disease. And then the non-GI symptoms are much more subtle, and so I think those are the ones to really be attuned to and aware of and think about celiac disease in your differentials. So iron deficiency anemia, patients with chronic fatigue that may or may not be associated with anemia, delayed puberty and amenorrhea, and then in older, women, those who are infertile also may have celiac disease. Even more subtle things like recurrent aphthous stomatitis, and then of course, I think the classic one that we all know from our ped sports is dermatitis herpetiformis, or a vesicular herpetiform rash, most commonly on the extensor surfaces of classically on the arms, but can also be on the shins and other areas as well. This slide I just wanted to highlight, there are some non-GI manifestations that are more associated with celiac disease than others. So, more of the growth, delayed puberty, short stature, anemia, of course, the dermatitis herpetiformis. I think the interesting one that I don't even always think about is dental enamel hypoplasia, not necessarily on the baby teeth, but on permanent teeth. And then hepatitis, the elevated liver enzymes aren't as strong of an association, but I think it's still something to think about. And then those patients who have kind of like recurrent arthritis, and then I've never seen a patient present with epilepsy with occipital calcifications, but there is an association there as well. So we'll go through the algorithm, but the serological testing pearls that I think to point out are that TTG IgA is the initial test of choice. We usually obtain that along with a total serum IgA to ensure that the patient does not have secretory IgA deficiency. And we'll talk a little bit more about that population as well, because they have a special propensity for celiac disease, and you have to think about those patients a little bit differently. Anti-endomysial IgA antibody can also be reliable in instances where TTG is non-diagnostic, so either equivocal, or we'll talk later about non-biopsy diagnosis of celiac disease, and anti-endomysial antibody can be an adjunctive test that you can do to make a non-biopsy diagnosis. And then anti-gliadin antibodies, while they're widely available and definitely still orderable, example. I very rarely use anti-gliadin antibodies, and they are no longer recommended as initial testing due to their inferior accuracy. So this is NASPGHAN's guidelines for the evaluation of symptomatic children with who are suspected of having celiac disease. So you can see on the top here, starting with your index of suspicion, the patient has the right symptoms, you get a history and physical exam, you consider celiac as part of your differential diagnosis. Again, as I mentioned, TTG, IgA, and a quantitative total IgA are the initial tests of choice. And I usually get those alone without other testing until those tests come back and I can evaluate further. And then if the TTG is abnormal, you would consult with us and most likely obtain an endoscopic duodenal biopsy for definitive diagnosis. If the TTG is not abnormal, celiac disease is unlikely at that point, and I would evaluate further for other causes of the symptoms. But you know, there are some instances where you may need to revisit that testing at some point in time. And then, depending on the histopathology, obviously, if it's positive, you proceed with gluten-free diet and a consultation with nutrition. If it's not, that's where some of these other tests can come into play. The anti-endomysial, genetic testing, really reviewing the pathology and ensuring that there are enough biopsies to make the diagnosis and or possibly repeating biopsies. So celiac disease is notoriously patchy. When we go in and do our endoscopies, we are making sure that we get a good sampling, both from the second portion of the duodenum and as far back as you can go is really the best, and getting samples from kind of all of that portion. And duodenal bulb biopsies have been shown to increase the diagnostic yield for newly diagnosed celiac disease by around 10%, which I think is not nothing. Sensitivity can be raised to up to 100% when you get 4 post-bulb biopsies combined with those 2 bulb biopsies. And I think, you know, that's one of the things that we think about when we have a patient who has a questionable diagnosis. Is the sampling sufficient to make that diagnosis, or do they need to be rebiopsied? And then HLA, DQ2, and 8, as we mentioned, are the genetic markers. They're glycoproteins that bind to peptides forming an HLA antigen complex that are recognized by CD4 positive T cell receptors in the intestinal mucosa. The actual test itself is a PCR of RNA that's extracted from cells. It's a blood test. And I think the big takeaway about HLA, DQ2, and 8 is that it's necessary but not sufficient for the development of the disease. So it has a high negative predictive value if you do not have those HLA alleles present, but the positive predictive value is pretty low. DQ2 is thought to be present in about 90% of celiac disease patients, and then about almost, you know, the other 10% are DQ8. But on the flip side of that, 30% of the general population has DQ2. So again, these are necessary for the development of the disease, but not sufficient. So for screening purposes, you know, this might help answer or clarify questions, and we'll talk about special instances where that might be needed, but I would not use this as initial screening. So let's talk a little bit about special at-risk populations who have a higher incidence of celiac disease. So I don't want to go too much into this slide. I thought this was just a nice list of conditions that are commonly associated with celiac disease, apart from type 1 diabetes, which is a very well-established relationship. So some of the ones that we will talk about include Down syndrome, IgA deficiency, and we'll also talk about first-degree relatives as well. I think the interesting thing is that autoimmune liver disease, you can have up to 13% or 13% of patients with autoimmune liver disease also have celiac disease. However, there are no clear guidelines for testing for celiac disease in that population. Actually, 2 of our fellows are working on a QI presentation around celiac screening and trying to increase the amount of screening that we're doing in that population of patients. So diabetes, up to 8% of patients with type 1 diabetes have characteristic histologic features of celiac disease. Most patients, interestingly, are diagnosed with celiac disease within 5 years of their type 1 diabetes diagnosis. So you can see here, so this group looked retrospectively at their cohort of patients with type 1 diabetes and looked at the timing of their celiac disease diagnosis. And they found that about 75% of patients were diagnosed between 1 and 5 years of their type 1 diabetes diagnosis. There was a small proportion of patients that had celiac disease beforehand, and then, still a very small, about 20% that were diagnosed after that, but your yield is the highest within 5 years of diagnosis. So the American Diabetes Association does have some recommendations, and I'm sorry that this slide is a little bit blurry, I apologize, but they recommend screening individuals with type 1 diabetes for celiac disease soon after their diagnosis of diabetes by the TTG, IgA, and total serum IgA, or if they're IgA deficient, IgG-based testing. And then they recommend, based on that study, repeat screening within 2 years of their diagnosis, and then again at 5 years. And then more frequent screening in children who have a first-degree relative with celiac disease. So moving on to Down syndrome, the prevalence of celiac disease in that patient population is somewhere between 5 and 12%. The majority of patients do have some GI symptoms associated with their celiac disease, bloating, diarrhea, failure to thrive, but 1/3 can be asymptomatic. Their screening recommendations do differ depending on the national body that you're talking to. ESPGHAN is the European Pediatric Gastroenterology Group, and they recommend HLA testing for this population, and then screening every 2 to 3 years, only if those patients have the genetic susceptibility, which, if you notice, is a little bit backwards from what we would do in other patients. And then the NASPGHAN, which is the North American guidelines, recommend periodic screening after 3 years of age. Younger patients, the TTG IgA screening may be falsely negative, and so that's why they recommend screening after 3 years, plus the patient has had a chance to be on a fully gluten-containing diet for at least a year, which helps increase your yields of diagnosis. Selective IgA deficiency, as I mentioned before, we check total IgA to screen for these patients, and up to 8% of patients with selective IgA deficiency will have celiac disease. But on the flip side of that, only 1 to 2% of all celiac disease patients have selective IgA deficiency. So those patients who do have selective IgA deficiency are at an increased risk. So because their IgA is low, the traditional screening test will not work for them, or will look falsely negative, and so we don't rely on that testing. If the patient comes to me, they're IgA deficient and they're symptomatic with classic symptoms, I would recommend doing biopsy rather than doing other testing. I think, especially if they're symptomatic, waiting for other testing, I think the risk of the benefit of diagnosing celiac disease outweighs the risk of biopsy in those patients. And then if you have a lower index suspicion, you do have a little bit more time, and at that point in time, I would recommend IgG-based testing. And then for high-risk individuals, I think, having HLA DQ2 and 8 in the back of your mind is always something to consider. And then again, with first-degree relatives, this is where the HLA DQ2 and 8 can be the most helpful because there is such a high negative predictive value. But the prevalence among first-degree relatives is anywhere from 2 to 10%. Obviously, twins are going to have a higher concordance, but even HLA identical siblings have about 30% concordance. So, I do think that, if there is a newly diagnosed patient with celiac disease, it is recommended that first-degree relatives get tested either with TTG IgA, or if the family prefers, HLA testing can be considered, because if they're HLA DQ2 and 8 negative, then there's no reason to test in the future. So the evaluation of high-risk groups, we would start with TTG. If the TTG is not abnormal, we would consider genetic testing to look at, do they even have the susceptibility? And then if they do, periodic TTG testing. There is really no good recommendation as to how often that needs to be. I think every couple of years would be sufficient and is typically our practice, but there is no definitive real definitive recommendation. And then if yes, you go down the pathway of diagnosing celiac disease. And then again, similar to patients who are not at high risk, you would either go down the gluten-free diet pathway or consider other testing to kind of help support or refute your diagnosis. And then in those patients who are at risk, those patients usually need to be greater than 3 years old and on a gluten-containing diet for 1 year, so that your TTG testing, you are increasing your yield. And then again, for those that are selective IgA deficient, you're going to use TTG IgG rather than IgA. So diagnostic dilemmas, I think these are interesting and fun to think about, and I wanted to go through a couple of some of the common scenarios that you guys might encounter when we're diagnosing or when a patient is diagnosed and not responding. So first of all, what if my patient does not want to scope? In North America, the recommendations are to get a biopsy. That biopsy-proven celiac disease is the gold standard. However, in Europe, they do things a little differently, and I think, in certain instances, I do think it is appropriate to make a non-biopsy diagnosis. So I just wanted to point out this is a large algorithm, and we're not going to go through all of this right now, but I did just want to point out that if the TTG is greater than 10 times the upper limit of normal, you can make a non-biopsy diagnosis by obtaining endomysial antibody and HLA. If the anti-endomysial antibody is positive and it needs to be on a separate blood draw, not the same blood draw, and if the patient has HLA, we would diagnose them with celiac disease without a tissue-confirmed diagnosis, and we would use gluten-free diet and then repeat testing for TTG to ensure normalization, and then close follow-up with a GI provider. And then I encounter this a lot where my patient comes in, they say, I think I have celiac disease or I want to be evaluated for celiac disease, and they're already on a gluten-free diet. I think it's worth noting that the sensitivity of serology and histology diminishes the longer you're on a gluten-free diet. And so the first question I always ask is, how long have you been doing that? I think HLA haplotyping is really helpful in this instance as well, because the absence of DQ2 or DQ8 will allow about 60 to 70% of patients to be reassured that celiac disease has been ruled out. And then if they are positive, then I would initiate a gluten challenge. And what that entails is reintroducing gluten. We usually say about 3 grams daily, which equates to about 1 to 2 slices of bread for 2 weeks. If they develop symptoms after reintroducing gluten after 2 weeks, we would proceed with serology and then duodenal biopsies if that serology is positive. If they're tolerant to the gluten after 2 weeks, because the longer you're on a gluten-containing diet, the better yield you'll have, you would do the diet for an additional 6 weeks to try and build up that gluten load and try and increase the chance that your serology will be positive. And then at 8 weeks, you would get serology. If positive, easy. They go for duodenal biopsies. If negative, we would repeat serology after an additional period of time. Some patients can have a delayed rise in their titers, and so that's where some of the nuance comes in with trying to diagnose these patients. And obviously, you guys don't have to remember all of this. By the time they're getting to this, usually, they're seeing a GI physician. But I think, those patients who are already on a gluten-free diet, it's nice to know or to counsel them like what to expect when they come to us. And then non-responsive celiac disease, I think, is a really interesting entity. The definition of this is persistent or recurrent symptoms, signs, or laboratory findings of active celiac disease despite at least 12 months of a gluten-free diet. It's estimated that about 7 to 20% of patients can develop non-responsive celiac disease. And there's a myriad etiologies, but the most common cause is continued gluten exposure. And this is what I'm particularly passionate about. I'm definitely no dietitian, but I've lived this, in my experiences with my husband. And there are really interesting sources of gluten that people don't necessarily think about. So one that I actually learned during fellowship was powdered dishwasher detergent that's lemon scented, for whatever reason, has traces of gluten in it. So we in our household have gotten rid of powdered dishwasher detergent. When my husband was first diagnosed, they had to ask their church to order gluten-free communion wafers. And then in children, Play-Doh and some art supplies can have gluten in them as well. And not necessarily that they're eating it, but that they're touching it and then touching other surfaces, touching food, maybe not washing their hands well. So you have to think about those non-food sources. And then interestingly, also the glue in envelopes and stamps can also be a hidden source of gluten. So I am the designated stamp licker, envelope licker in my household. And then other, dietary factors can be at play too. It is thought that, other than the protein, the gluten protein that in gluten-containing foods, there are also fermentable oligosaccharides, disaccharides, monosaccharides, and polyols that can contribute to continued symptoms despite a gluten-free diet. I guess I'm saying that wrong, that in gluten-free foods, that there are positive FODMAP foods that can contribute to continued symptoms. And then small intestinal bacterial overgrowth, and then one that's not on this slide, pancreatic insufficiency as well. So, the evaluation of this always starts with a careful dietary history, non-dietary history. What are their exposures? What are the hidden sources of gluten that you need to be thinking about? And if you've excluded all of those, you may consider a repeat EGD just to make sure, are they getting gluten in their diet that they're not thinking about? Are there still some signs of celiac disease on histology? And then you can also consider a colonoscopy if diarrhea. Interestingly, microscopic colitis, it can be found in up to 4 to 5% of patients. And then, as I mentioned, some of the etiologies other than that, lactose or fructose intolerance, bacterial overgrowth, functional IBS-like disorders. So there are a lot of reasons why patients who are on a dedicated gluten-free diet could still be having symptoms. And then I did want to point out refractory celiac disease as well. These are persistent signs of celiac disease despite greater than 12 months on a gluten-free diet. It only occurs in about 10% of patients with non-responsive celiac disease, and as you recall, about 5 to 20% of patients who have celiac disease can have non-responsive celiac disease, so it's a very low number. It's only 1 to 2% of all celiac disease patients, and it's very rare in children. There are 2 types, and both types are most common in patients greater than 50 years old. So I mention this only to say that we very rarely see children who do not respond to a gluten-free diet. And then I think the hip new term these days, and maybe you guys get asked about it a lot, is non-celiac gluten sensitivity. And that is patients who respond to a gluten-free diet and have symptoms when gluten is reintroduced. The prevalence is kind of all over the place, and I think some of that depends on how aware practitioners are that it exists and giving it a name when patients mention that they get better with gluten elimination and they have symptoms when it returns. Anywhere from just 0.6% in the US, which I think is probably climbing based on the patients that I've been seeing, and then 7 to 13% in other countries. We suspect that some of it has to do with small intestinal permeability that's caused by gliadin, and there have been some studies to suggest both adaptive and innate immune responses are the part of the pathophys. And then there are other proteins other than gliadin that may be implicated as well. It's really hard to diagnose, obviously, because there's a lack of biomarkers. But I think the other big point is that if you really suspect this, that a full evaluation for celiac disease is required. Again, HLA is not sufficient for celiac disease diagnosis. And as you can see, about 50% of patients with non-celiac gluten sensitivity are positive for HLA DQ2 and 8. And there's a higher frequency of non-celiac gluten sensitivity in patients who have first-degree relatives who do have celiac disease. And we're not entirely sure why that association occurs. The proposed diagnostic pathway in this instance would be a placebo-controlled blinded gluten challenge, where you do a gluten-free diet and kind of wash out all the gluten for 4 weeks, and then the patient does not know what they're reintroduced, gluten versus placebo. Again, you can imagine this is a very hard thing to do. For 1 week, you wash out over a week and then cross over with either gluten or placebo on the other side to see when gluten is actually introduced, but the patient doesn't know it, do they have symptoms? So that was a lot to get through, but I think some of the things to take away from this are that celiac disease is not rare. You have to be very attuned to the non-GI symptoms and have a high index of suspicion for testing for celiac disease in those patients. That there is an association of celiac disease with other autoimmune diseases and genetic syndromes. That for us, TTG-IgA is the initial screening test of choice in almost all instances. It is possible to make a non-biopsy diagnosis of celiac disease, but I would make this diagnosis in conjunction with your friendly neighborhood gastroenterologist. Checking for hidden sources of gluten is very important in non-responders to ensure that there is no reason that they're still having gluten exposure. True refractory celiac disease in children is very rare, and that there is an increased reporting of non-celiac gluten sensitivity as well. So thank you guys very much for your time and attention, and I'm happy to field any questions.
Thank you, Dr. Wenzel. That was great. If anybody has any questions, feel free to type them in the chat room, or if you want to take yourself off of mute, go ahead and ask a question. I'm going to go ahead and share some information on how to contact Dr. Wenzel. So please bear with me real quick. And as you know, as most of you know, we have opened up the new Lurie MD line. It's a new direct dedicated line just for physicians. So you can call for specialist questions or about appointments. So really like for you to try to use this if you have any need to talk to one of our specialists directly. And then once again, thank you, Dr. Wenzel. Here is how to get a hold of her. And you can reach the department at 312-227-4200. Her direct line is 312-227-5421. And if you want to email her, she is at aawenzel@luriechildrens.org. This has been great, and I see we have a question in the chat room here. So, Dr. Wenzel, at what age should I test a young child for a first-degree relative with celiac?
Very good question. I don't think that there is a completely right answer. I think you could think about it 2 ways. One way would be to obtain genetic testing right off the bat, because I think HLA typing would be really helpful in this instance, that the patient is DQ2 or DQ8 positive, and they may develop celiac disease at some point in their lives and have a higher risk with that patient or with that first-degree relative. Or you could think about it as, or if sometimes the insurance company, as they did with my husband's family, didn't cover the genetics, and I think that might have changed since he was diagnosed, but you could wait until, and I would say probably similar to the patients who are in those high-risk autoimmune disease categories, I would wait until probably about 3 years old. The chance of your TTG-IgA being not being falsely negative is better. And then also you need to make sure that the patient's on a gluten-containing diet for at least a year. And so like very, very young patients who are like a year old and still doing some formula or still doing maybe a lot of milk or something like that, which is gluten-free, like I would maybe question the testing at that point in time, but I think HLA testing would be really helpful in that instance, and that's probably what I would do.
Thank you for that question, Dr. Leckman. I really appreciate your asking questions here in the chat room. Does anybody have anything else? If not, like I said before, we are recording the session and I will be sending it off to you. And feel free to share the session with your colleagues so they can meet Dr. Wenzel as well. And you'll be seeing more invitations from me from me introducing our new specialists within the Skokie, Northbrook area. But thanks again for everybody who is attending today. And I look forward to seeing you all soon. And Dr. Wenzel, thank you again for this great presentation.
Yeah, thank you so much, Chad. Thank you, everyone, for your time and attention. I really appreciate it.
Okay, thank you. Have a great day, everybody.
Bye-bye.